All right. A very, very good morning, good afternoon, good evening to wherever you all are. Very, very warm welcome and thank you so much for joining us. We have many more participants today and they'll keep on joining in. As it is, the meeting is being recorded, so we'll definitely share it with all of you. Thank you for joining in. And it is my privilege. My name is Dr. Amanpreet Vasir, founder and managing director of Hridayamrit Foundation. And with me, I have Dr. Priyansha, who's been very kind as the Vice President of Board of Activities and the Project Lead for Women in Cardiology Initiative. And to welcome us all, we have Dr. Kamala Tamirisa joining us actually live from the American College of Cardiology's Congress in New Orleans. A very warm welcome, Dr. Tamirisa, and thank you so much for being a part of us in the leadership and doing this. It means so much to all of us.
No, thank you so much for having me. And I want to make sure that you all can hear me and it's pretty clear.
Yes,
Yes, Salman?
yes,
Yes,
honestly, thank you.
great.
And we can, if you all are comfortable, please feel free to turn on your video so that we'll be knowing who we are chatting with, to see some faces. That'll be really nice. But I think let's get started very, very, quickly. So first of all, welcome on behalf of the Hriday Amrit Foundation. We are a non-profit organization based out of India. Our vision, our mission is towards empowering the next generation of medical students, residents, fellows, trainees, early career professionals all around who are interested in the preventive cardiology space with a special focus to health literacy and prevention of cardiometabolic risk factors as well as other things related to it. And we are a young organization. We are actually celebrating our first anniversary. We've grown quite a lot in the last year and hoping for many, many more goals to be achieved in the coming years. Thank you for everyone who's been a part and is a part of this call as well. So I'll quickly jump in right quickly with women in cardiology. So this is something which we all imagined when we started. And it's something which I could have never imagined doing from a South Asian perspective. Many of you have already heard about what is women in cardiology, why was there a need for it. But I always felt that this is something which is extremely important, and I've been very fortunate that I've been able to attend many meetings which have been hosting these events, and a part of a very, I would say, very less people who are actually women. So a couple of men and boys there as well, kind of advocating for the same cause. Because having worked in this field, being an early career in this field, I think there are persistent gaps when it comes to awareness, research, and care for women's heart health. There are many, many other facets to it. It's not just cardiology, it's about the awareness about that there is something which is directly linked from right from underrepresentation in clinical trials to equity, visibility in terms of equal opportunities and empowering stuff and other things also in terms of not just clinical research but also other clinical domains. And I think there was a need felt that also that that there are so many important organizations doing this work outside of India, but not a lot of people do understand this from the Indian and South Asian perspective. So to get that started, we were very proud to share this initiative. And we got a really nice team with legends in the field, passionate people who really want to make a change from a perspective of an early career, and growing in that domain is something which we are launching today. So this is our first, inaugural session, and we're very happy that Dr. Tamirisa, who's a very strong voice in this domain, who's worked relentlessly, has done amazing work, and we're very happy to inaugurate this initiative today. So looking forward to it. Next slide, please, Priyansha. So a little bit about myself and what I'm doing. I'm an incoming Somers Scholar, MPH candidate, Johns Hopkins, and been in this domain advocating from a young perspective at Hriday Amrit. And now I think before starting off about the women in cardiology, just one last sentence would be that this is something which came out of passion and with a long-term vision. This is not just one webinar that we'll be doing. It's many, many different activities, opportunities which will also be bridging the gap between India and other countries in this domain. So I would say stay tuned for what's coming in. We would be happy to host you, help you out in whatever capacity we can. We are building as we are growing together. So we welcome that. And I'll now, I think, call Priyansha to kind of launch the WIC initiative and then go on with introducing Dr. Tamarisa to the podium. Thank you so much, everyone.
Thank you so much, Aman, for introducing the cause and our foundation. And I really want to thank Dr. Tamrisa for joining us for this session. and giving us all the insights and perspective that she has gained in this career pathway. Personally, I am Dr. Priyansha Singh. I am a graduate from India. I have been working on this cause for quite a while. I have been part of for certain working groups in ESPC and a lot of ones who have been working towards, preventive cardiology, especially for females. My main vision for this initiative and in joining hands with Hridayamrit is to not only focus about the awareness and about what preventive measures we should be taking in, but also to include disparities which come from low socioeconomic countries and low socioeconomic backgrounds who have limited resources when it comes to health, and where females fall back into the race and getting them as much needs and getting the needs met as much as we can. So that is one of the visions that we have launched in WIC. WIC is not just an initiative; it's a collection of vision and collection of pathways we are trying to adapt. We are trying to get into research and advocacy and trying to raise awareness as much as we can in evidence-based studies. At the same time, we are trying to complement it with our on-field activities, trying to reach these communities who are not able to get access to healthcare, and trying to expand the knowledge as much as we can, not only in the terms that we are able to convey to the experts, but also in layman terms where they can understand what we are trying to give and what is needed for them. And that is the main vision for WIC. I really hope that we have more helping hands join in and, launch further into this perspective. Getting to know about what we are focusing in today's session is we are mainly trying to talk about we're mainly trying to cover up these gaps, as we know that right now cardiovascular disease is one of the leading cause of mortality among women, and yet it still remains under recognized, underdiagnosed, and undertreated. So today we have Dr. Tamirisa, who is going to explain further about how do we work towards covering up these gaps, and how do we work towards exploring the clinical and systemic challenges, at the same time trying to improve outcomes, especially for the female cardiovascular health. I mean, if you would go ahead and introduce our esteemed speaker.
Yes, thank you so much, Priyansa. That was wonderful. So, welcome again, Dr. Tamirisa. So, we with us today we have Dr. Kamala Tamirisa, who's serving as an associate professor of internal medicine under the Division of Cardiology and also the director of electrophysiology research. She's been practicing for many years as a clinical cardiac electrophysiologist and has also extensive work in the arrhythmia and the cardio obstetrics domain. She's working currently at UT Southwestern Medical Center in Dallas, Texas. Dr. Tamirisa, over to you. A very warm welcome again, and we're looking forward to learn from you and also understanding into what kind of different challenges you might have navigated in your personal journey and learning from that. Thank you.
Mhm. So this is great. I appreciate the warm welcome. And I don't know what time it is, probably late in the evening. And I'm super impressed that so many of you showed up, and we'll have a nice discussion and Q&A as directed by Priyansha and Amanpreet. Thank you.
Thank you so much. I think we'll jump right in about learning from your journey, your experiences in this field. So I think the first question that we have for you is that what inspired you to pursue cardiology as a specialty, and what was the inspiration behind that?
Great question. Samanpreet, before I go on, I just wanted to acknowledge Adriana Mares, and she's here. She let me borrow her laptop, and because my computer crashed and it didn't turn on, and she literally helped me sit in a corner and make room, silent space, so I can talk. So thank you, Adriana. So the reason I bring that up is as you listen to my journey, it's people have to lift each other in order for us to succeed. And the premise or the overview of my talk, which I repeat a lot, is we have to get rid of non-abundance mindset. So we'll touch on that as we go on. So to answer your question, what initially inspired me to pursue cardiology, I didn't think of anything other than cardiology since I was a child. I remember even in middle school in India, I someone asked me, "What do you want to do?" I said, "Well, cardiology." And I don't know why. I'm the first cardiologist in the family. I'm the first physician in the family. I come from a family full of engineers and PhDs. So don't ask me. There's no story, there's no inspiration other than it's just a calling. Sounds cliche, but cardiology was something I always wanted to do. I think the draw was the mechanics of the heart pump, how intricate and how interdependent, and there's such a synchrony between the mechanics and the electrical part. And that was the inspiration. And just a funny anecdote here is when I decided to go to medical school, I did my medical school in Banaras University in Varanasi. And my dad actually was very sad that I wanted to go into medical school. He came all the way and he said, "No, you're not going to do medical school. You need to go into engineering or become a scientist or something." And so, because of the lifestyle or whatever his concerns were, but that inspiration was from within, and the pure science was my inspiration.
Well, thank you so much for sharing what you had gone through and why you chose this as a specialty. It's quite interesting because many of us who's joining are medical students, are residents and fellows. So I think this is very pertinent to not just their interests, but like you mentioned, the word calling. And that's, I think, something very closely tied to what we are actually trying to do as well, which is purposeful and is actually making some kind of a difference. If even if it's helping somebody, I think that's what is the calling that I've understood from what you said. So thank you so much. Moving to the next question, as a woman working in cardiology, how would you describe your experience navigating the field during your training and early career? And I think just expanding on that question, it just not limits to challenges, but a holistic understanding about your journey as a woman in this field.
So, I just want to give just a little journey background. So I finished medical school and then I came to US. I, came as a visiting research scholar, just like you are going to do at Johns Hopkins, Summerfeed. So I got that opportunity. So I came here and early part was how do I build on my research were mostly on apoptosis, programmed cell death, and in mice models. So I kind of looked at those. Then I realized that I was drawn to the electrical system, EP, the ECGs, and that's how I chose cardiac electrophysiology quite earlier on. So as I came here, holistic experience was from the research, applications, going through internship, the residency, and then the fellowship. The journey had number one, I'll touch on support from others, and that's super important. Wherever you go, um, you need to have a village around you, people who support you, people who believe in your passion. And how do they get a buy in? Your family members will support you, or your best friends will support you. One key piece of advice that I learned is networking, knowing people around that share your passion. So do not hesitate to reach out and say, I am interested in this, and find the common ground. You will find plenty of people who share the same passion, the drive, the vision. So that's what I did. I built a network, and my mentor, he is a huge name in apoptosis in acute MI model. So he actually encouraged me, put me in touch with other people. So from the bench research, then I went into the clinical world. Again, the second experience was education in India was phenomenal. So leverage that. Whoever is deciding to, if you decide to come to US or wherever you practice, Indian education system really laid the foundation for how detailed and basic knowledge was rock solid. So that gave me the confidence to take it to the clinical world. If I don't know the basic, I don't have the basic knowledge, and I didn't know what basic anatomy, physiology, biochemistry, the subjects that we all take. So leverage that. You will enter as a very confident person because your knowledge base is strong. So then I use that. And the difference I noticed when I came here was basic foundation was there, but the practical application is very different. So how is it? Everything that I learned had 3 or 4 ways I can adapt it to the patient care. So I use that and try to connect with patients and their families. I still take a long time to connect with them. So the early career of my time was mostly building a village around me, knowing who's in alignment with what my vision is, and tuning out noise. There's plenty of negative forces, noise. We can't focus on those. We just got to focus on passion, your core group, and also slowly molding and building on your strengths that you learned and the things that you still have to learn and grow and expand. And as you all know, medicine, you learn every single day. So my early career was pretty much on that. So I started in New York, went to St. Louis to do my internship and residency. Then I went to Ann Arbor, University of Michigan for cardiology fellowship. Then also did electrophysiology fellowship and also got cardiac MRI fellowship. And after that, I started in a practice and built that. Since we are in Women in Cardiology Forum, I will one piece of advice, whether it's like my own journey or watching others as I mentored people, do not put family life, family planning, if that's on your radar, on hold, waiting for the career. Make sure that the family is in parallel to your career dreams and growth.
I think this is so nice. Thank you for sharing your journey and what your experiences have been. And I think although I have understood a lot of things which you've mentioned, I've also, I mean, the vision that you've talking about, that the alignment with the long-term vision is supposedly very necessary. And when it comes to work-life balance, that is something extremely important, especially when we're talking about young girls and women who are navigating into this career. And this actually makes me remember a very interesting incident when I was interviewing you for the Fits on the Goal last year at ACC. I was talking about the work-life balance or the harmony, and then you had reiterated and said that it's actually not just the balance, it's actually harmony. So to be in that space is something which I think a lot of people, I think, would be interested to learn more from you about as well.
You want me to go ahead and comment on that? Comment?
Absolutely.
Yes. Yeah. I think, it's one of the things I talk a lot about. So work-life balance means your work is on one corner, family is on the other corner. That's not it. And if we start to look at everything in silos, then we'll never find the harmony. So somehow trying to find that harmony or peace in whatever you're trying to do. So the way whether this is 100% applicable or not, bear with me, but I'm married to another interventional cardiologist, and we do have two older boys. One is in college and one is in high school, and we do have a dog. And I do take care of my in-laws, and so I have a full household. And how do you balance or how do you find the harmony between that work and your patients, your research, and what you bring to the work day? And how do you find time to make sure you're there as a spouse, as a mother, and as a daughter-in-law, any role, as a best friend, whatever roles you play in your life? One lesson I learned is live life in segments. If you try to go all in, trying to do everything at the same time, we will not be able to do a good job at everything. Neither will we succeed. So, for example, if I said I want to be a leader, run a program at a hospital or an organization, and at the same time I want to have children and I want to get married. At the same time, I want to be there as a perfect, there's no perfect, but as a daughter, as a sister, as a friend. You're putting yourself a lot on your plate. And what's the risk? The risk is you're going to lose pleasure in this, and the burnout and the stress is going to step in. So initially, when I was had finished my fellowship, towards the end of the fellowship, I went ahead and had my kids. I would recommend, if you can start having family earlier on, and if you have support, please do that. Do not put your family planning on hold until your career is completed, because career growth is a constant process. It's a dynamic process. So once I had my kids, I actually took 3 months of postpartum leave with both the children. And there was a one point where the practice did say, well, we can't pay you. I said, fine, don't pay me. But I'm not coming back. And some people don't have that luxury. I'm married to another cardiologist, so we had enough money. But if you're in a financial situation, at least finding to take time for yourself. And during that time, I did not take up any opportunities to lead or grow programs. Opportunities came, and I told them very respectfully, thank you for thinking of me. Right now, I'm focusing on having children and raising them. And when I have time, then I will be, please reach out, and, I'll reach out to you. So one analogy I use is, do not be in the driver's seat constantly with your foot on the pedal. You're going to burn out. This is a marathon. This is not a sprint. So it's okay to sit in the back seat and observe and make space for yourself, and then come into the driver's seat whenever you need to come into the driver's seat and take full charge. Now that my kids are older and I have more time, and so over time, that stage of life came, and I took the leadership position, leading the EP outpatient arrhythmia service line. And then I built some programs around cardio obstetrics, and also right now teaching, mentoring, and making myself available. So the harmony comes from two important things to wrap this topic. One is, live life in segments. You will not be able to do everything at the same time, and do not live in a feeling of missing out. The FOMO is so real for the younger generation. I see them trying to do everything at the same time. They're going so fast. At some point in life, you will feel the brunt of it. Second thing is, know your own North Star. What family, number of kids do you want to marry? Do you don't want to marry? What do you want to have? That's your decision, and that's your North Star. Stick to that North Star. Don't get swayed by what's going on around and then feel like imposter. Oh, am I missing out on something? So those were the two things I learned.
Thank you. Those are really, really valuable pearls, because I think this resonates with most of us who are actually affiliated with at least cardiology or medicine at large. That, I think it gets so overwhelming, and, the FOMO is real. I think ACC says that this year as well. But the only thing is that I think the part that you put very beautifully was, live life in segments, because otherwise it can get too much. So we need to move away from the driver's seat once in a while to give space and balance it out, because especially things are getting so demanding, there is so much noise around. I think that focus and that north star vision, I think, is really applicable to, I think, everyone who's on the call today. So thank you so much. Priyansha, I think you can continue with the rest.
Yeah, sure. Thank you so much, Dr. Tamrisa. I think putting in words really makes a lot of difference. As someone who is, trying to get into cardiology and have a longer visions and see to the future, I think you have put a great pathway for me on how I should move ahead and how I should be planning it all. So thank you so much for your words, and thank you so much for your vision and sharing your perspectives. Moving on to our next question. It's, over the years, considering you have been, adapting cardiology for so many years, how have you seen the representation of female in both in sense of female who are practicing cardiology, but at the same time, the females who are trying to focus on women's cardiovascular health evolve and change in practice and in evidence-based studies?
So I think you had two different questions in there. So I'll start with the workforce representation of women in cardiology. In US medical schools, women are, 55% are women and 45% are men. So we are doing great in medical school. And then in cardiology, it goes down by, we are about 27%, 25%. Still not too bad, but we need to do better. But have we improved a lot over time? Yes, for medical school, we have. Even in the field of cardiology, I'm very hopeful that over time it will improve. But you have to remember that everyone who goes through medical school might not be choosing cardiology as a field, right? They might be going into some other specialties for whatever reason. Um, Identifying those barriers is important. So, I have written multiple papers on these, and the one of the surveys that Jack had looked at, the barriers, and the survey that ACC has done has also shown the work-life harmony. At that point, it was called balance, was an issue. And then also environment, the culture, the pay gap, these still exist, but they're improving. And if you ask me what would we be in about 10 years, we don't know, but hoping that with leaders like yourself and male allies, we do need men to support. And I think we'll be able to change that. And so with the workforce, we know the barriers. I touched on a few. And just with the barriers for women who want to pursue invasive fields like electrophysiology, interventional cardiology, and those. We've done surveys, and recently one of my surveys was published looking at, again, radiation risks or standing for long hours, orthopedic risks in pregnancy planning, delayed pregnancies, complications with pregnancy, infertility rates are high. So I think the workforce, we still have a lot of work to do. Women will increase in number, and that's my hope with the way that we are working towards it. Are we there yet at the destination that we envisioned? No, but are we moving the needle 100%? And what does the system need to do? Because women are motivated. I think the system needs to make the field more flexible, training durations shortened, and culture and the environment and the barriers need to be addressed at an institutional level and also an individual level, trying to basically, take the support of everyone around you rather than going solo would help. And then your second question is, cardiovascular disease in women. Now, the link there is, we talked about workforce so far. We know the gaps. We talked about those. How do you tie that to the cardiovascular disease in women? And you, Priyansha, you did give a very important fact. Cardiovascular disease is a number one killer in women. And how many people know that? So number one is educating people. And how do you tie that to the workforce? So the question always comes when we do, when I write or I speak, people ask, why do you talk so much about workforce and how do you tie that to the cardiovascular disease in women? We have multiple studies showing that there is sex concordance. Women physicians who treat men or women with MI, diabetes, hypertension, we have studies that women physicians tend to do better with communication. Outcomes from the patient's angles are better. Women surgeons, the recent study actually showed that their complication rates are lower. Patients perceive that the care that was provided to them was their perception. They were left more satisfied. And so the strength in us is some debate on the topic of EQ, whether it's real skill or not. But I feel like emotional intelligence, where we connect with people, is our strength. And if we could tie that to the science and hopefully the barriers will be overcome, we'll be able to change the needle. Now, cardiovascular disease in women, that's a bigger topic, right? I mean, we have gaps in every. I can start with my field. Sex differences in atrial fibrillation. We've written papers on it. We know pathologically what the differences are. And we still have, even in US, access to care is not the same as the access for what men receive. We had one of my mentees had a poster yesterday. Women with atrial fibrillation do not get referred for an ablation at the same rate as men with atrial fibrillation. And what are the causes? Is it because women have different type of symptoms? Is it because women do not seek care because they're too busy taking care of others before them? Or is it a fallback on the system? They go to the physicians blow off their symptoms and say, yeah, it's okay. And so they reach the labs or the procedure ablation labs later, and higher risk of complications. So that's a huge topic. So to wrap up this, workforce gaps are closely linked to the cardiovascular disease in women, that gap, and because of sex concordance data and all the scientific data that we have.
Thank you so much, Dr. Tamirisa. I think that definitely highlights our main issue. I think that like you mentioned, that there were so many systemic issues that we are facing currently, and I think the best way would be to approach them one by one and try to target and trying to utilize all the resources that we have, that so that even if we are not able to minimize all the issues that we are facing, all the systemic gaps that we are facing, but at least we are able to focus one by one and trying to minimize them as much as we can. So that definitely makes sense. Uh, Moving on to our next questions. While you have definitely covered this part already, if you would give us like a quick liner on what advice would you particularly offer to medical students or early trainings who are already, trying to envision and trying to get into cardiology training in the future?
Very good. So study, which you all do. You study very hard, and so I'm not going to say that. So keep studying, give it your best. And one thing it really helps is having an abundance mindset. So if you're a medical student or early career and you have an opportunity, let's say to do research, okay, so you have a good mentor and someone reaches out, you're connected. If you don't mind, my request for you is reach out to two other people in your own circle, knowing that they're applying for the same positions that you're applying. This is hard, but it's a request. And I have done it and it works. So reach out to two other people in your own circle who you kind of see do not have as many publications as you do or as many connections as you do. Or they're in programs where they don't have any resources. Some might be in bigger programs. I'm using All India Institute of Medical Sciences or something like that. And someone might be in a rural program. They don't have as many resources as you do. So reach out and just bring those two people in. Talk to your mentor who wants to do research and you have this idea and say, would you be okay if I brought one more person or two more people and we'll all do the work together? So divide and share. By doing that, number one, you're collaborating, you're lifting someone else around you, and believe it or not, your platform will get bigger over time. That leads to larger network, and it's also a very kind gesture to let others grow with you. And abundance mindset is something you have to intentionally practice. The more and more we say it's me, 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 I get it. At some point, that me is going to be a lonely journey. So I think having those that yeah, there's room for everyone. There are places, will everyone get a position the same year that applied to cardiology? Oh, it's a competitive field. And so, well, maybe take a break, 1 year and do some research. Think of how to use that time. Do you want to be a hospitalist and then do research or do volunteer work or community, whatever leadership project you want to take? Some might get in super fast and some might take time to get into places. But the important thing is not to take it too hard if you fail, because you will fail. We all will fail. We fall, we fail. The strength is how resilient are you when you fail whether you don't get into a position that you apply, you don't get a title that you want, something like that. You just take a step back and say, I had the resilience. I know I fell. I know someone else got that position. I didn't get it. Instead of turning that into cynicism or negativity, you say, it's an opportunity for me to actually be resilient and grow with that. So don't give up too fast. Have the perseverance. Be kind to people around you, and always be on the lookout who needs your guidance. And some of your peers might need that guidance.
That's a really good point that you have mentioned, Dr. Damrisa. And I think that's one of the reasons why even this initiative came into vision. I had approached Manpreet, and it was a great idea to see that he was already thinking over it, and then we worked towards it. And he knew who were the right people to reach out to you, such as yourself, and the most amazing, empowerment board that we have reached out to, who have agreed to join us and give us their guidance. So it's a really great thing that we are learning such values from this life and from this end, and it's going to help us out in the future while we pursue this career again ahead. Aman, if you would like to comment on it as
Yeah,
well.
this is quite interesting because I was just about to say the same thing as Priyansha, that Dr. Tamirisa, you mentioned about this kind of mentorship and peer mentorship as well, and kind of doing it all together, not just at once. And I think that was the basic ethos behind launching this initiative as well, because many people, it's not just about the WIC that I'm talking about, it's at large cardiology and opportunities for students in India. And most of them haven't even heard about this terminology. Most of them do not have the awareness and knowledge. So, kind of, we're trying to bridge that gap as well in terms of knowledge and opportunity sharing for them. So, thank you for taking that up as well. Priyanshu, we'll have the next one. Great. So I think we've talked so much about the integrative kind of approach to cardiology and early career perspective, and I think deep diving into something just about the subject per se. Being an electrophysiologist, in your perspective, I would ask that what do you see are those gaps that still require attention or greater attention when it comes to sex-specific differences for disease prevention and management in cardiology? Is there something particular that you'd like to highlight?
Sure. So the sex differences in the field of electrophysiology, atrial fibrillation, we talked about that. So women tend to be older when they seek help for atrial fibrillation. Women tend to have higher risk of stroke than men. And when we do ablation for women, they tend to have more of atypical flutters than men. And they have pathologically in the left atrium, they have more abnormal circuits in the left atrium, so non-pulmonary vein triggers. So, so that's the pathology. The difference is there in the pathology. And like I mentioned, their symptoms are different, just like MI patients are different than men. So by the time they seek help, might be delayed, and there's also access to care issues. Now, your question was just focusing on AFib for this and keeping it very streamlined. And so your question was what can be done? Well, the few things that can be done is the the few things that can be done are number one, education. So educating women, patients, telling them that this disease exists, these are the symptoms, these are the risks, and on an ECG, what does it mean if you have AFib? So educating our patients, taking time, how do we and where do we start the education? What you're exactly doing, educating yourself as a medical student, as an early career, or whatever stage you're at, and also your patients, spending a little more time in the communities around you. And if there's health illiteracy, undoing that is the first step to trying to close the gap. That's number one. And then how can we do these? Basically, volunteer work, going to the community centers, identifying health illiteracy spots where people don't have any knowledge, and educating them. Number two is giving them the resources. So if we talk about women with AFib, you do all the education, we do all the great work, and you said, yep, they're educated, and the woman has AFib. What does she do next? We say, yeah, come for an appointment. I make you an appointment. Yeah, you have to drive about 45 minutes to come to the clinic. And then she's looking at her life and saying, I have three kids. I have to go to school to pick them up. How am I supposed to get to the appointment? So I think as system, what we need to do is use the technology. We have AI, we have telehealth, we have remote monitoring, remote monitoring and remote health. If there is bandwidth, if there is technology, using that, or even a telephone visit, connecting with the local primary care physician in there where they can do an EKG, they send it and you're on the phone and, talking to them, hey, I reviewed your EKG, this is the disease, and I'm going to send a prescription for a blood thinner, a stroke prevention as a first step. So doing, I understand the limitations, or I should say, I understand limitations to an extent in US. In India, I haven't been there for a long time, but I know it's much more harder with the socioeconomic, disparities and all those. But if we just sat here and said, yes, there's poverty, there's health illiteracy, but making those small changes and collaborating with the community, internal medicine doctors in those villages would help educate the primary care doctors, who refer patients to us. And then the third thing is basically, trying to offer, if they are not able to afford, if the healthcare systems, universities, healthcare systems are able to set aside funds for community work, give them subsidized medications, one life at a time, change as many as you can. Easier said than done, I know. But these are at least small things that we can do. And you have the human power of having such motivated students and, everyone wants to grow. And in return, it feels good to help in a small way in your own little circles, and also helps build your own CV and shows the leadership.
Absolutely. Thank you. I think you very well put it in a point-wise fashion that how do we start it, right, from education to empowerment to resources. And I think that's even more true for resource-constrained settings like India, where there's just so much limitation when it comes to not just referrals, but also basic treatment that women can get. Because it's not just so much about underrepresentation, it's more to do about just being aware of the fact that this can also happen. Like when the AHA movement started about Go Red for Women, it said that because cardiovascular diseases are the leading cause of mortality in women also, because there was a need felt to do so. So thank you so much. And I think the other two questions on this slide, I think, were very pertinent to what you've just answered. A very interesting question that has come up in the chat is by Sahana, who's asking, could you talk about any patient whom you saw with an atypical presentation and how the treatment course changed?
Thank you for that question. Yes, of course. A great question. So, patients, I can talk about quite a few patients, but I'll just start with one of the patients who is in a rural area outside Dallas, and she drives about 2.5 hours to see me. And the first time she saw me was 6 years ago. And he was having chest pain, and it was episodic chest pain, and she initially thought, yeah, it's acid reflux. She's a middle-aged, and she said, oh yeah, I'm menopausal, I'm gaining weight, maybe it's acid reflux. Of course, she took Tums, whatever she could. Then the symptoms continued, and her husband actually said, you've been complaining of that chest pain that here and there you mention it comes and goes, and maybe you need to see the doctor. The local primary care doctor sees, and he gets an ECG. Rhythm was normal sinus rhythm. They did a monitor, for 24 hours, ultra monitor, and that was fine. And then they got an echo and did a stress test, and that was fine. And then she was told that, yeah, maybe you have spasm of the coronary arteries. This is a very good primary care. I was quite impressed that he even thought of that. But then he said, yeah, just, take it easy. Maybe it's stress and menopause and blah, blah. So she continues. And then one day she wakes her husband up and says, I can't move my left side of the body. Okay. And she had a stroke. So he takes her, then she gets transferred. That's when we meet. I meet her. And, she had a stroke. And when she came to the ER, she was in AFib. And then she says, I'm having that chest pain again. And on the monitor, she's in AFib. So this tells you that chest pain can be angina, could be angina due to obstructive CAD, coronary spasms, or just anxiety that's really used too frequently, too loosely for women. But in her case, the chest pain was indeed AFib. And unfortunately, because the monitor was only done for a day and she didn't have any chest pain when she wore, the diagnosis was not made. How could we have changed that? Probably monitoring her for a longer time, and then making sure that she had that chest pain when she was wearing the monitor. So doing it for maybe a month, asking the husband and the patient, how frequently do you have this chest pain? And she would say, yeah, I've been having once or twice a week. Then maybe the monitor should have been done for 2 weeks. Then she would have had that chest pain. And that same chest pain was AFib. And maybe she would have been on an anticoagulant before she had the stroke. And how did my management change? Well, with her, it was the odd symptom. Chest pain is not a very common symptom with AFib, but, and of course, lucky for her, she recovered from the stroke. She followed through with the physical rehab and everything. She still has some mild weakness on the left side, but I went ahead and her EF was a tad low too. By the time it could be a combination of the stress-induced cardiomyopathy, Takotsubo, with that AFib or whatnot. But I went ahead and ablated her AFib. And, so far it's been 5 years, and she's been doing good. She's going to continue the anticoagulant. And that's how those are my take-home points from that case.
Great. Thank you so much. I think that was pretty interesting to hear as well as a case scenario, because this is something which happens so often and it just goes missed. At least majority of the cases who are referred in this setting, they either might just be missed or misdiagnosed. So that's really important. I think moving on from what we have been discussing, I think it will be interesting to have a discussion on the South Asian population, because as the latest guideline said, that it is a enhancing risk factor when it comes to cardiometabolic stuff. And I think, Priyansha, if you'd like to take this question about why cardiovascular health women and why is it that the South Asians are at a greater risk?
Yes, definitely. So the next question we have is when we talk about South Asian population and these females, what, according to you, in your clinical practice, have you observed are the unique, cardiovascular risk factors or any challenges that clinicians should be more about of, and how do you think they should approach it to tackle it?
Well, I have to make a disclaimer here because I have not published a lot or done research in South Asian women as such. But having said that, we know, have I taken care of patients? 100%. And do I know the studies yes, I read the studies. So in the context of South Asian populations, I'll divide it into few groups. One is the anatomy itself. We know, Priyansha, that women tend to have smaller caliber veins and arteries when compared to men. We knew that all along. We just have thinner blood vessels, right? So now with that, we had diabetes or pre-diabetes with metabolic syndrome. Well, the caliber is small. Then you have this microvascular disease, intimal thickening, and then basically the higher risk of CAD, which we know. So anatomic substrate in South Asians, as a general fellow, I remember cathing South Asian people, and I'm like, ooh, these blood vessels are really thin, because we just tend to have thinner. And these ectatic disease, very small distal disease, not good enough for even a bypass graft to be put in. Again, I'm not a surgeon, but those so anatomical differences are there. What makes it complicated and what can be done? We can't change anatomy, we can't change our genes, is our lifestyle. Carbs to some extent are okay, but we eat too much carbs. So, and then we don't exercise as much. And I think it's important to, if one thing we can educate ourselves, including me, is walk more, walk more, walk more, walk everywhere. And just get that 10,000 steps in if you're a busy person. But if you have time, go out, take your kid out, play with them, even in your yard, or just if you're walking with a kid in your stroller, just go for a walk, 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 walk. And another thing, to be honest, lately I think I haven't done a very good job, but most of the time I try to get in my 10,000 steps. I take stairs, I push that. And another thing is 3 to 4 days a week, I think most of us should be able to set aside time for some kind of exercise, whatever you like, with whatever resources, whatever space you have. So make sure to do that. And then the third one, especially in women, is if you're not healthy, your family is not healthy. If you're not there for your family, you're doing no good for anyone. And women, we tend to basically say, oh, let's feed the kids, let's feed the husband, let's do laundry, let's do this. And then 10 o'clock or 11, whatever time dawns, we're too exhausted. And we say, well, I'm not going to do anything. So I focus on women, take care of yourself. And please, I'm not even preaching. I have made a lot of improvement. I was in that same boat. I do everything for everyone, and then it's my turn. The older I get, I realize that my joints are creaking, the back hurts, and I'm like, no, I need to take care of myself. So going back to the cardiovascular disease, anatomy, caliber of the vessels, metabolic syndrome, prevent diabetes, eat healthy, exercise, exercise, exercise. And the last thing I will say is mental burden and insomnia is something very important. So get that sleep as much as you can at whatever time. So, and less time on the social media or whatever young people do nowadays, but sleep is very important. And I do my best. I try to get in. If it's a weekend, I'm not on call. I sleep 8 hours easy, and I take a break. So I think those, I don't know if I touched a lot on what you were looking for, but I wanted to bring in my perspective and also as you care for your patients.
No, definitely. It's very interesting that you mentioned the essential of hitting your 10K steps every day because I remember this recent anecdote where I was rotating with this cardiologist and he had this similar vision that he wanted his patient to get his 10K steps. So he made them participate in challenges in online apps, and they used to have this challenge of which of his patient is able to hit the 10K steps first, and on the next visit they would get a little surprise from his side. So he saw that it was really essential. It really helped his patient to implement them in their daily life. Just to have like a quick follow up on this question, as you know, especially talking about South Asian population, especially talking from an Indian family that I come from, a lot of times we often see that females are also very reluctant to reach out for help, reach out for their symptoms. They try to dismiss them as this the normal, strains that they got from the household works. So, what do you think that we as medical students or recent graduates who are trying to do on-field activities should reach out to these females to make them realize the importance of reaching out to get checked and get themselves checked by a doctor and try to look into the symptoms in depth rather than dismissing them as just a regular strain?
Well, thank you for that. I just wanted to add something that we both were discussing about the 10,000 steps. And so, maybe your organization, your foundation can do like walk for cardiovascular health or something like, whatever it's in kilometers. So, whatever kilometers, just do walk, in their own small villages and, connect with people in the language that they speak, the culture they live in. And I think if you approach them that way and said, we do some walk, and also, by the way, we can do some blood pressure check and do these. And so community programs, with those are important. Now, to answer your question about how do we take care of our elderly family members or our family older members in the family, I'll start with an anecdote. My mother-in-law, she is a master's in English literature, super educated woman. And, this was when I just had my second child, and I just had my second child, and I was busy, postpartum and whatever. And she told me 6 hours after that, hey, I can't, there's something going on with my left eye. I can't seem to be able to see. It's like something is going on, like waves in my eye. And I said, for how long have you had this? And she's like, no, you're taking care of the baby. And my husband was on call. And she's like, you guys are busy. I actually woke up at 4 in the morning with this, and I didn't want to tell anyone. And now I can't see through my left eye. I'm like, I was livid. I was mad at her. I said, what do you mean? It could be retinal detachment. It could be, vitreous, whatever. What's going on? And, right away I rushed her. The husband came, we took her, and she did have retinal detachment, and it was delayed. And thankfully, surgery was done, but her vision never 100% returned to, what it was before. So I bring that anecdote. And so I think as a culture, if you, I don't know about changing the whole world, but even if you reached out to your own family members and you said to them, hey, asking for help is okay. Ask for help. Because I think in our culture, sometimes it's like we don't want to ask for help. I don't want to bother. So ask for help. Please tell us earlier so we can help you. So, um, so reach out to your family members and say, please ask for help. It's okay. Even if you see that I'm running around, I'm in medical school, or medicine is a busy field, just know that this is the life I live. Just call me or just tell me, hey, something is going on. I will, if I don't have time, I'm going to ask a cousin or a neighbor or whoever, can come for help. That's number one. And number two is, that's an individual on a smaller level that you all can make an impact. On a little bit of a larger scale, again, I go back, take a village around you, and then educate them. Just the key, cardiovascular disease is a big entity, right? You can't cover everything. So maybe focus on CAD or heart failure or stroke. Just take three things and then tell them these are the symptoms, these are the medications, there are treatments. And then last is to touch on their lifestyle choices. If they're smokers, encouraging them, showing them the data. But again, reaching with a cultural concordance, language concordance. That way, a person who doesn't speak the same language and goes and says things, people are like, I'm not interested in what you're trying to tell me. So in US, I have done work in the communities, mostly around teenage health and obesity through, because of my kids and my passion. But we work a lot in youth settings, and the illicit drugs, the tobacco, the stress. In these, I think those small changes will hopefully, together they'll become a larger impact.
Yes, thank you so much, Dr. Tamrisa, for sharing your personal perspective. And I definitely relate to this because, as someone who is also a first generation doctor, I think the hardest patient for me to convince is my own family and trying to get them to reach out to people and try to get them help. And I totally agree with the fact that a lot of times, even I'm not aware of the health issues that goes around because they think I'm busy with med school and further. But thank you so much for sharing that anecdote with us.
That's actually very interesting because you've talked about youth engagement, you've talked about cultural relevance, and even that 10K thing. So we do definitely organize walkathons and heart health marathons or just walking activities for people. But I think being more mindful of this from now, I think it will be more important to do it in a language that they understand, which is culturally relevant to them. Because even when it comes to reading about stuff, I think many people don't really understand or comprehend what they're reading when it comes to those WhatsApp forwards, those random messages that come in. So I think breaking that barrier is also something we're trying to target.
And if I may, I just wanted to say something, Amanpreet. So, you all are building this, right? As your team grows bigger, even if, you can task the medical students and say, you can adopt a village, and that's your village. That, let them adopt a village and say, this is your village. And each of them maybe do a pre-survey, and each of them will adopt a village, then come up with a nice health focused, protocol, something. Maybe they do it for like 6 months, and then post survey, do a post survey, and it will be, maybe 10 or 20 areas, and that you can publish and show as a pilot study as to how small grassroots efforts do make a big change.
I'm so glad that you're sharing about this, and this is something which we are actually working on right now. So this year, unlike last year where we've done a lot of different activities, this year I didn't want to talk about this because this was a separate session, but we're going to be launching Mission Hriday Path, which is India's path to heart health, and this is exactly what we are doing. This is exactly the adoption of those little communities through a youth engagement network, from a survey to educating them in a language which they understand. We did partner with the ASPC to also help us validate those education materials, because most of the literature that's available, it's not pertinent to the South Asian, especially the Indians or the Pakistanis or Bangladeshis. So doing those cutoffs and obviously translating them into a language they understand, followed by the post survey in terms of really have they really understood, or is there some difference that we're trying to make, starting on with pilot projects and then followed by a nationwide rollout. So hopefully that goes and takes a good shape as well. Thank you.
Yes, so thank you so much for such an informative discussion. I really hope that we are able to adapt that idea further. Moving on to our next question that we have pertaining to the South Asian women. As Dr. Tamrisa, you're focused more on the EP section. Hormonal transition are something which are significantly impacting the arrhythmia burden in females. How do you think, particularly in South Asian females, these are some of the recognizing or the presentations that clinicians should be aware of, or something that you have actively worked in your own field of practice?
Knowing the, menopausal changes, educating people. Menopause is something that we need to start talking about, and hormone fluctuations are real. And so, number one starts again, coming up with like a simple visual of what the symptoms of menopause are for the patients. That way they know. And then during that time, perimenopausal stage, PVCs are very common. So if patients do come during that time, telling them that 60 to 70% of perimenopausal women will have PVCs, and to basically, you know, tie that, of course, their CAD, EF symptoms and the total burden, but reassuring them if everything else is normal and they don't have any CAD, ejection fraction is normal, and that's important. And then we also know that as women get older, AFib also goes up, burden overall. And in general, women tend to live longer. If they tend to live longer, then we start to see more AFib. So educating again, and does the treatment change? No, the stroke risk goes up. So the treatment actually intensifies in the postmenopausal stage. The anticoagulation thresholds are lower, and treating, again, one last thing I'll say, we don't have data as such looking at, estrogen, progesterone fluctuations and, do they translate to reduced stroke risk, blah, blah. But we know that the QTC does prolong with the fluctuations in the estrogen levels and the progesterone. So there's work that needs to be done, a lot of research in that space. But at least we can start off talking about menopause as a physiological stage of life. We don't just ignore the menopause and we say, yeah, it's a stage of life. They're moody or they're irritable. It's beyond that. Number two is also educating them that they get older, stroke risk is higher. And also, it's very important. Again, I go back to saying walk every day. You don't need any equipment. Post-menopause, weight gain happens and all these. At that time, if people start to exercise, they might have some resistance. Oh, my knees hurt, my body hurts, and stuff like that. Encourage your own family members saying, start exercising now. There's no excuse. And you're not going to eat too many snacks in between. And you're just going to hydrate yourself and walk, walk, walk. So even if you changed, I lecture my mother-in-law all the time, and she does. She literally walks. And I'm very proud to say that my father-in-law, who's in 80, and he literally walks an hour every day. And the first thing I ask him as soon as I come home, who walked today? And make it a family thing, make it fun, you know.
Definitely. Thank you so much, Dr. Namrita, for getting into it. Do you just a quick follow-up question on this? Do you think that, fields like and fellowship opportunities like cardio ops who are trying to work into this matter as well, have they evolved over time and have they also shifted their focus, especially in terms of menopause and the post-menopausal areas? And, have they been able to implement it among their patients that they have been looking into?
Yes, so a lot more studies are being done. More and more research is coming. And so, women and cardiovascular disease in that component, I don't know about cardio OB because that focuses on maternity and pregnancy, but women and cardiovascular disease, a lot more data is coming on menopause, its effects. As you know, right now, we went from no hormonal replacement to maybe hormonal replacement. So that's a change in the paradigm. We just need to adapt to it. I feel like the data is coming, and in EP, I can tell you we get patients who have autonomic dysfunction, and some of those symptoms are tied to fluctuating hormones. And I sometimes wonder, do you give hormone replacement therapy to these postmenopausal women who have the significant autonomic dysfunction, or you don't? But, in our lives, we've been told that hormone replacement is bad. But now that it's been undone or to a degree, I'm looking forward to having more data in specific cardiovascular areas with regards to the hormone replacement.
Definitely. And I do agree. I think that while, female cardiovascular health is something that is underrepresented, especially when we talk about hormonal transitions and these age groups, it becomes more underrepresented. So I think opening a dialogue in this realm is very important. So thank you so much for sharing your perspective. So to have a quick wrap up of this session, I think we should now move on to what are we looking to the future goals. Aman, do you want to take over?
Sure. I think this has been very knowledgeable for me as well. I think not just understanding about women in cardiology, but mostly about what we really want to focus on meaningfully. And I think there are two questions on this slide, but I'll kind of combine them into one because I feel that we've spoken about so much. You've really told us the everything. I would say everything about what we need to know in this session. But what now? As WIC is inaugurated today from Hridayamrit, people are doing such amazing work. It's still a field which needs more voice outside. What do you think, I would say, in short, would be your kind of statement to what's the future ahead? What lies ahead for all of us in this domain pertaining to WIC and initiatives like this which are continuing to emerge?
Think it's a perfect time, and great work again. I'm your fan, Harmanpreet. You're phenomenal what you do. You're just continue this momentum. And the momentum should include educational material that are digestible for the patients in the language they speak, like I said, concordance. Second is even, I think there's so much of data comes out in cardiovascular disease. It's an umbrella term, right? We talk about cardiovascular disease. Are you talking about hypertension, lipids, AFib, CAD? Even having small take home like infographics, which are like workable for even medical students or the people to take and talk to their patients and even educate themselves. Like if you put me on the spot and said, what's the latest study in hypertension and sex differences, I would pause because I don't know, I don't remember. I've read studies, but I don't remember everything. So doing that education, bite-sized education that's relevant to the population that we're serving. So that's the education part. Second is what you're already doing is continue that network and abundance mindset and grow together with literally kindness. Just grow together with kindness and share that knowledge. By sharing, a lot of ideas come, use those. And because that means empowerment. And the third is a continued commitment and knowing each of you is here because you are gifted and talented, right? If you were not committed to whatever and you didn't have the passion, you wouldn't be here. So consider yourself as very lucky. A lot of people are not here and on this platform, so you're very lucky. And use this. And just the last thing I always end. It's a very philosophical term I use, but it comes very handy. Own the gratitude just every day, even if it's the worst day of your life and you're trying to make a big change, just doesn't go. I beg you just to sit somewhere and say, what am I grateful for today? I got up today. I could walk. I didn't have knee pain, or my family is safe and healthy, and my health is good today. I'm still alive. So just use that and don't burn out too fast by going and doing a lot. But I'm very proud of you all doing this, and I appreciate and super honored to be here.
Thank you so much. I think that's so reassuring to hear from you directly. And I think I'll kind of follow up on each point that you've just mentioned, right from education. So just the recent guidelines came on dyslipidemia, and everyone is talking about it at conferences, on social media. There's so much buzz about it. I opened the document, I wanted to read about it, and it's an exhaustive document because there's so much to read. And I said, I'll do it today, I'll do it tomorrow, and that didn't come. But then I saw this write-up by somebody who's just written the 10 pearls about the guidelines. What's the major thing? And that was so much more knowledgeable than going through that exhaustive literature. So I think I'm absolutely in support with what you're saying in terms of those bite-sized kind of infographics or knowledge that needs to be imparted to people in a language that they understand. And that would actually empower them. So that's exactly what we were trying to do with the inaugural session, with you kind of coming in and guiding us in what aspect could we grow in this capacity. Because especially in a country like India, where we are talking about South Asian cardiovascular health, the literacy is not that high when it comes to early career trainees. And especially topics like women in cardiology and other associations as well, which are allied to cardiovascular disease, need a strong voice. So thank you for doing this for us. And I think it's been really nice to kind of get your insights and about the abundance mindset as well, kind of growing together on that. So I'll quickly open the podium for questions. If there's anyone, you can please feel free to unmute yourselves or put it in the chat box. If not, we have just two questions with us we'd like to ask you. And then this has been long, but I don't want to take a lot of time. So if there's somebody, you can please quickly kind of unmute yourself or put it in the chat if you have a question for Dr. Tamirisa. So So, not to waste time here, so till the time someone's doing that, I have two questions that came up actually. One of them was quite interesting. They wanted you to suggest any good write-up or something that you would recommend for reading, not just about women in cardiology, but something that you suggest for early career people to read. It can be a book, it can be any literature, a research paper, anything. Do you have something in mind for that?
Hmm. Tons of books and literature is there. I don't know if this person is looking for scientific material or self-development material. Do you know, Aman? Amanpreet?
I think it was a very broad question. We just wanted some good.
Okay. So yeah, for scientific and cardiovascular disease, I mean, you have platforms after platforms, but choose the field. Let's say, if you want to go into heart failure or passionate about it, then at least like reading Jack Heart Failure. And then looking, second one is the Heart Failure Society, what work they're doing and what late breaking clinical trials, a guideline documents came is one. So you won't be able to read all the journals and everything and know everything. So look at one or two your passionate items and then read up those. So Mother Society, for me, it's Heart Rhythm Society, but for ACC, American College of Cardiology, and, the guideline documents. And apart from science, let's see, the bunch of empowerment books, or if you have not read Mel Robbins, if you have time, she has an audio book, Mel Robbins, and it's called the Let Them Theory. How many of you read that or heard? So Mel Robbins, and the book is called Let Them Theory. Let Them Theory. It's just empowerment. Let them is basically her message is, if you're worried all the time about what others are going to think, are going to judge, what are others going to think, or maybe they're hurt, or maybe why did they not respond, and things like that are stopping you from your pathway. Then that her voice and her book is very data evidence based, but very useful.
Thank you so much. I've already taken note of both of what you've said and will definitely give it a read as well. And I think the last question for you, I know it's been a long session, but the only question that came up, which was quite interesting as well, which was you talked about capacity building and you talked about how people who are obviously involved in initiatives like the WIC can help shape it. What about men? How do they help advocate? How do they support it? And how do you think that they can contribute meaningfully to women in cardiology and initiatives like this, both at home and at
Huh.
work?
Of course. Yeah. So I'm a living example because of my field. Most of my mentors are men, and initially, but I have tons of women mentors and role models and sponsors. So the way men can help is, if you're a man and here, please help out at home. Share the workload. Doesn't mean women don't do anything, but men and women, we divide in our household. Whoever gets home first cooks, and we text each other, and we have excellent communication, and my husband is my best friend, and we don't put stress on each other. If he's tired and late, I say, I'm going to take care of things, don't worry about it, focus on the patient and the case. And so given you know spouse or family, whoever at home, life, you have to live in the compromise world. It doesn't work like I want it this way, you want it that way. It's just never going to work. So compromise a bit. Let your spouse compromise or your partner compromise, and meet in the middle, and just have fun along the way, and don't lose the sight of the power of friendship. Whether it's a friend, just lean in and also lean out. So that's number one. Number two is, what was the second part of the question, Amanpreet?
Both at home and at work.
Outside, at
Yes,
work,
yes.
yeah. At work, I think communicate. communicate and ask. Women are not good at asking. They just brood in their own mind. They think everyone is supposed to read their mind. People are not here to read anyone's mind. If you need like 2 days off or you're stressed, speak to a colleague, ask your chief, go to and say, hey, I'm not feeling good today. I need help. But then in return, make sure to pay it back. Be, keep it a bi-directional. So please ask, please negotiate for what's a fair pay, what work, hours you want to work. And believe it or not, people want you to succeed. People do want us to grow. It's just that sometimes they don't know what we want or what our life is unless we communicate. It'd be hard. So men, and the other thing, when you do any initiatives that are women in cardiology, make sure to include men, because we do need male allies, and they will support. Like my husband, like supports me a lot, and so incredible supporter. Without him, I would not be able to do everything I wanted to do and raise kids and do stuff. So
Absolutely. Thank you. Thank you so much. I think it's been a wonderful session, and I think we've had a holistic understanding about what we wanted to aim at. And I think this was our inaugural webinar, and I think we had no one better than you to kind of start this initiative with. So thank you for supporting us. And I'd urge everyone who's on the call, Priyancha has sent a feedback form, a post-event questionnaire. If you can kindly fill that in, that'll be great. And I think, thank you so much again, Dr. Tamirisa. I think you're at the ACC and it's a busy time, but you still took out the time. That's work-life harmony as well for us, I would say, in terms of like calling in from India. And yes, thank you.
no, I appreciate. Yes, no, you're phenomenal. Your foundation is great. Thank you, Priyansha, for having me, and continue to grow and just enjoy life. And I'm just, anything, if I can be of any help, just do not hesitate to reach out. Okay. So I'll have fun. Okay. Bye.
Thank you
Thank
so
you
much.
so much, Dr. Tamrisa.